And I see the university's role and our student and staff role is really giving away what we know and trying to be supportive to community and engage in that way. And so we've tried to answer their call as best as we can over the last several weeks as we've all adjusted under the COVID pandemic. And then finally, we'll talk a little bit more about what can be done to minimize COVID-19 in correctional facilities. And as part of this, we're going to showcase the video that we were asked to put together on COVID in correctional facilities and that specific project. So from there, I'm going to turn it over to Rachel, who will give us a brief introduction and overview of incarceration and health disparities.
Thank you, Dr. Shlafer. It's really an honor to be here, and thank you so much for having us. So as Dr. Shlafer said, we have a large, diverse audience, and so we do want to make sure we all are on kind of the same page about what mass incarceration is and how we got to where we are today in our criminal justice system and in our correctional facilities. So this is just a brief timeline. It does not do justice at all to the events over the last 40 years that have led to where we are, but wanting to recognize the major key points around the history of mass incarceration. So in the 70s, President Nixon declared a war on drugs, which is really when incarceration started to increase a lot in the country. It increased about 500% since the 80s because of the war on drugs. And it also disproportionately impacted people of color. And that's really important as we look at COVID-19 today and who is locked up in our correctional facilities. And so in 1986, the mandatory minimum sentences were declared, which meant that crack cocaine would result in 100 times longer sentences than powder cocaine, even though they're the same substances. And African-American folks were more likely to use crack cocaine. And so 85% of people locked up for crack cocaine are Black Americans today. And that has been reduced. So the discrepancy between crack cocaine and powder cocaine has been lowered to 18% or 18 times greater for crack cocaine, but is still a disparity. And then in the 90s, Clinton introduced the 3 strikes laws and the truth in sentencing, which means folks have to serve at least 85% of their sentences and cannot be released on good behavior or anything like that. And these were incentivized by the crime bill that was passed by President Clinton. And so there's a lot of money in the passing 3 strikes laws and truth in sentencing in each state to fund prisons and to fund mass incarceration from the 90s. And so that leads us to where we are today, which is with 2.3 million people incarcerated in the United States, which is a quarter of the world's incarcerated population. Go ahead, thanks. And so as you probably know, incarceration impacts men the most. We have 93% of the people in prisons and jails today are men, but women are an important population that we think about in our correctional facilities too, because their path to incarceration is very different than men, and their needs are also very different within correctional facilities. And so this is reflective of the national breakdown of gender, but also Minnesota's breakdown of gender in our facilities. And so there is a difference between jails and prisons. Jails are shorter sentences being served, less than 1 year typically, and also people who are waiting for trial. So they're people who have not actually been found responsible or found guilty, and they may just be waiting to post bail or be arrested. And so 37% of Minnesota's incarcerated populations are in jails right now, and then 63% are in prisons. And prisons are people who have been charged and they're serving sentences that are longer than 1 year. And so there are 10 prisons in Minnesota, but only 1 for women, which is in Shakopee. And then there are 84 county jails, which is about 1 per county, but we have 87 counties in Minnesota, and Hennepin and Ramsey both have 2 facilities, a pretrial and a post-adjudication facility. So they separate folks out based on where they are in the process. And it's important to note that jails have quite a bit of turnover, which is a high risk for COVID bringing in and out of the facility. And so that is a population that is very much at risk right now. And also in Minnesota, we have quite the disparity based on race of who is incarcerated. So Black Americans and Black Minnesotans are incarcerated at 11 times the rate of white Minnesotans, and Latino folks are incarcerated at 2.6 times the rate of white Minnesotans. And there are also a lot of health disparities that face correctional populations. So the rates of infectious diseases such as Hep C, tuberculosis, HIV, and STDs are much higher in correctional facilities than the general population. And also over 50% of incarcerated individuals have at least one chronic condition, such as diabetes, high blood pressure, or asthma. And these are often conditions that are correlated with higher risk of severe COVID infection and fatality from COVID-19. And pregnancy is also something that makes folks' health a little bit more at risk for COVID-19 infection, though that research is not quite out yet. But anywhere from 6 to 10% of women in prisons and jails are pregnant, though there is not a universal screening for pregnancy. So these numbers aren't actually known across the country. And it's also important to know that because of all of the history of mass incarceration, the correctional population is aging and they have longer sentences. And so there are a lot of folks that are older in our prisons and jails who could also be at risk for severe COVID-19 infection. And all of these numbers impact women and Black, Indigenous, people of color at higher rates than men and white folks, even in the prison system. And now I will turn it over to Andy to tell us about the environment that puts people at risk for COVID-19.
Thanks, Rachel. So as Rachel had mentioned, there are already existing health inequities that particularly are salient for correctional facilities. But in addition to those factors, the very environment in which residents of correctional facilities exist also put them at considerable risk for infection. So for example, the physical environment, we know that jails and prisons are often overcrowded. They have a dormitory sleeping arrangement, very much shared recreational and eating spaces, as well as poor ventilation. So we often think about, college dorms or long-term care facilities as being areas where these factors are centered, but these are also challenges that residents of correctional facilities by definition can't avoid, right? So it puts them at especially at risk. In addition, there are already sanitation restrictions that make proper hygiene, proper public health practices very much a challenge for residents. So for example, soap and other hygiene products are highly regulated, mostly because those are often alcohol containing. And there are also restrictions on spare clothing or spare bedding. So again, having clean, hygienic resources can be a challenge. And then finally, we know that on a nation level, our jails and prisons are often understaffed when it comes to medical personnel. Just like almost every other place in the United States, there's a lack of PPE available, as well as existing copays. And again, these are nationwide trends, and they almost certainly vary between state, between county, between facility. But these are all factors that we need to take into account when we think about this intersection between criminal justice and COVID-19. Next. So as you can imagine, these health inequities, these environmental challenges all coalesce and really make jails and prisons especially vulnerable to COVID. So we can see in recent nationwide news that there's language being used such as jails are petri dishes, hot spots, something that's going to explode, emphasizing that these facilities are not equipped to be a hospital. They're not equipped to care for very ill people. So again, this is an extreme and rising concern for these communities. Next. And just to really drive that point home, as of yesterday, according to the New York Times, 9 of the 10 largest COVID-19 clusters in the United States are in jails or prisons. And I'll just call your attention to the fact that these are really all over the country. So Ohio, Tennessee, California, Texas, a very nationwide trend where jails and prisons are particularly vulnerable to COVID-19 outbreak. Next. And specifically in Minnesota. So here we can see positive cases of COVID-19 over the past month or so, with a very sharp rise over the past week to 89 positive COVID-19 cases. And unfortunately, we heard that earlier this week, we had our first COVID-19 related death in a Minnesota correctional facility. Next. And here we can see that the rate of COVID-19 positives among prison staff has been relatively stable over the past month, ranging between 0 and 5 across the state since about mid to late May.
And Andy, one thing I just want to acknowledge here is that these are data from the Minnesota Department of Corrections and data that have been retrieved, input into the Marshall Project and the COVID Prison Project data tracking. I just want to acknowledge that our Department of Corrections has done a really incredible job of doing daily updates, and several county jails are also actively posting data, including Hennepin County. And I think this becomes a really important point in terms of data and data transparency and understanding the scope of the public health problem as it relates to correctional facilities in our state. And so one, I think, take-home message for audience members today is really thinking about how we can't know what we don't track, and the importance of all jails and prisons reporting regularly COVID data so that we can understand the nature of this pandemic in our own state and our local facilities.
Thank you, Dr. Shlafer, for bringing that up. And then I'm going to hand it off to Karmen.
All right, so we've gotten a little bit of background on incarcerated populations and how COVID-19 has affected them. So I'm gonna kind of run through how we got here and what we did. So to start off, the reason that we have been involved in this work with incarcerated populations is we have been teaching, a group of students have been teaching a health education class at the Minnesota Correctional Facility, Shakopee. So we have been teaching that class since January of 2019. We've taught, it's a 12-week class and we've taught 4 quarters. So we started this work back in the fall of 2018 through a graduate field experience to develop a curriculum. And we adapted these materials from the Rush University Medical College. They had a health education course for the Cook County Jail. And so we took that material and adapted it for a prison population and also added additional material using a public health lens and creating a 12-week curriculum instead of a 10-week curriculum. So we have been teaching that now, like I said, for 4 quarters. It's been really successful. We've done a small process evaluation on it, and it's been very well received, and we've really enjoyed our work there. Next slide. And so through that work, Rebecca in mid-March had reached out to the group of students who works at Shakopee and said that she had this time-sensitive task to create a 2-page health information sheet on COVID-19 that could be distributed to incarcerated populations. And this was as a direct request from Dr. Winkleman at the Hennepin County Jail. And so a few of us who had the time and availability jumped on board, and we had a draft information sheet completed by the end of that same day that the request went out. And then we were able to send it over to Dr. Winkleman for review. It was then formatted by Rachel and printed for distribution the following day. So we really knew that it needed to be done fast, and we were able to deliver on that. And then about a week and a half later, we had another request from the Hennepin County Jail if we could make an informational video on COVID-19 and incarcerated populations to be played in booking. And a small side note, myself and Karmen work at the Minnesota Department of Health, and there had been some work around maybe creating materials for incarcerated populations through the Department of Health. And so we had created a draft PowerPoint that highlighted basically the same information that the information sheet had. And So Rebecca thought that that would be a really good starting point for developing this video. But we, once again, knew this was a time-sensitive task. We wanted to get it done, and we weren't able to wait around for the Minnesota Department of Health to create those materials and release them. And so I adapted the PowerPoint that I had made for MDH to have a more generalizable one that could work for any facility and be branded for anyone. And so, sorry, Rebecca, did you want to say something?
Yeah, I was just going to say, Carly, do you want to say a little bit about some of the things that we took into consideration when we were developing the info sheet? So timeliness, we definitely wanted to get it out, but there were a lot of considerations that we talked about as a group with regard to plain language and simplicity. Will you share just a little bit about the process with that?
Sure, and you can go to the next slide too while I talk about it, because it highlights some of those key points. So yeah, one of the biggest things was that we wanted it to be in plain language at a 5th grade reading level or lower. We wanted this material to be extremely accessible for everyone and also easy to digest in a short amount of time. Another really important thing, this was really early on in the COVID-19 pandemic, especially in Minnesota, and we wanted to highlight those recognizable symptoms. And kind of differentiate between like what does COVID-19 look like and what does like a cold or, you know, allergies or something like that look like. So that was really important, and we kept that in mind. Another really important thing was having basic hygiene that was easy to implement, and this kind of ties into having the tailored language for jails and prisons. So a lot of the COVID-19 education materials that were out there and are out there now are tailored to someone who lives out in the community, such as language like stay home when you're sick. And that's not something that applies to someone who's living in a jail or prison. And so we were really mindful of having language that was applicable to like how their living situation currently is and things that they had the agency to implement on their own, such as like washing their hands often. Along with that, we wanted to share what's going on in the outside world, out in the community, to let them know that everyone is being impacted by this right now, and it's an unknown and scary time for everyone. And so we talked about, you know, states closing everything down, people having to stay home, not being able to go out, you know, to restaurants, not being able to go to work, things like that. That was also really important. And then lastly, we wanted to make sure we met the language needs of the jails and prisons in Minnesota. And so as the timeline shows, we had both the information sheet and the video transcript translated into Spanish and Somali so that we could meet some of those language needs. And then if you want to go back to the timeline real quick. And so just to kind of wrap it up, we also had some medical students who came on board from a connection with Dr. Winkleman to help create the transcript and initial narration for the video. And then that was completed on April 2nd. And the video has since been shared with national partners, thanks to Dr. Silva at the Hennepin County Jail. Next slide, you can go to the info sheets. So this is just briefly wanted to show you what the info sheet looks like. And then the next 2 slides show it translated into Spanish and Somali. And now we would like to show the video that we made since it's pretty short.
I promise I'm getting there. All right. Are you seeing it yet?
No.
Okay, give me 1 second. Resume share. Okay. And now are you seeing it?
Yep.
Great. Okay.
This video provides a brief introduction to COVID-19, This resource was developed by students and faculty in the School of Public Health and Medical School at the University of Minnesota. First, COVID-19 is a respiratory illness, which means it affects the lungs. COVID-19 has not been found in humans before. The most common symptoms of COVID-19 are fever, cough, and trouble breathing or shortness of breath. You may also have muscle aches, a sore throat, and diarrhea, although diarrhea is less common. COVID-19 is spread when a person with the infection coughs or sneezes near you. It may also be spread by touching your face after touching things that someone who is sick has touched. This is because the virus may enter your body through your nose, mouth, or eyes. Some people are at higher risk of getting sick from COVID-19. People who are older than 60 years, have a medical condition like heart disease, diabetes, or lung disease, or people with immune systems that are not able to strongly fight off illnesses, like those who have HIV/AIDS or cancer. They are at increased risk. However, young, healthy people can still be infected and spread COVID-19. People can also have the infection and spread it, but may not feel sick or show the common symptoms. This is why it's important for everyone, even if you feel healthy, to follow best practices to help reduce the spread of the virus. There are a number of ways that we can reduce the spread of the virus. These practices include covering your coughs and sneezes, washing your hands, and not touching your face. Whenever possible, try to keep at least 6 feet between yourself and other people. If you are experiencing any of the key symptoms of COVID-19, let jail medical staff know right away. COVID-19 is different than the flu in a few ways. First, COVID-19 is more likely to cause trouble breathing and serious infection than the flu. It is more contagious than the flu and does not have a vaccine available like the flu does. In response to COVID-19, cities and states are encouraging social distancing. This means not gathering in big crowds, staying home as much as possible, and staying at least 6 feet apart from other people. Many states, including Minnesota, have closed public schools until May. Most concerts, sporting events, and religious gatherings have been canceled, and all restaurants and bars are closed until May. The jail is also taking important steps to reduce the spread of COVID-19, including increased cleaning and limiting who can come in the jail. Thank you for your attention to this message. We appreciate your efforts in helping reduce the spread of COVID-19.
And now I will turn it over to Karmen to wrap us up.
Thank you, Carly. So I'm going to go into response across several regions of the country, and COVID response varies across the United States and can even look different from facility to facility within the same state. Generally, decarceration has been the answer for many jails and detention centers. This is done in several different ways. One way is reducing bail to zero, so people are able to post bail, but are still expected to show up for their court dates. So those charges that were filed against them and the reason why they're in jail are still held. Some individuals are being put on conditional administrative leave where they're able to be released temporarily. A lot of states and counties are doing this for folks that are medically vulnerable. Some places are simply releasing individuals who are arrested for minor or nonviolent offenses without any conditions, so they are just free to go due to the situation. There have also been early release plans set in place for states like California, where individuals can enter a community supervision program if they are within the last 180 days of their sentence. So these efforts have led many facilities to reducing their population down from anywhere to 40 to 60% of their normal capacity. It is worth mentioning, however, that these decarceration efforts are more quote unquote popular in jails and are less common in prisons. And we'll get into some of the practices in prisons. So jails in particular have also been isolating individuals for 2 weeks if the capacity allows, because that's the incubation period for COVID. Of course, for a lot of facilities, this is not necessarily possible. Some are very small. So they tend to opt into things like symptom monitoring, like temperature checks.
And then isolation for specific individuals who are at a higher risk for coming down with an infection. This could be someone coming from the community who they find out from the health department has had direct contact with someone who's infected, or someone like someone's cellmate tested positive. So they have also reduced the amount of prison admissions in some places. So since mitigation efforts, like I said, can look a lot different in prisons, some jails are transferring folks, or not transferring folks, excuse me, who have been sentenced to prison when they otherwise would have been transferred. And then this goes specifically into what some prisons are doing, and that is point prevalence testing. So this is a useful tool used to assess the spread of a disease in a given population. What that means is all involved are tested. So all staff that work there, all the folks that live there, they're tested en masse to see how many are infected, who they work with, where they work within the facility, and whether or not they're asymptomatic. And I think something interesting to note here is that point prevalence testing is finding a lot of asymptomatic individuals. So what this does is they can use this data to help them understand where there are gaps in mitigation efforts, who they need to isolate at any given time, and where there are high risk infection areas within the facility. And many facilities across the United States have also used this practice on more than one occasion so that they can assess the spread over time from one PPS to the next and see if their original mitigation efforts worked as well from the first time, where they could see where all their cases were. And then, like we're talking about today, some educational programs have arisen, but I will say this is probably the least used method. So materials like we're talking about today are one example of educational materials that have been specifically suited for individuals who are incarcerated. And as pictured in the slide, the Marshall Project runs a News Inside update, which is also suited for incarcerated individuals and runs on a kind of somewhat of a subscription basis. And they developed a guide for COVID-19 that utilizes plain language, like Carly was talking about, and gives a lot of in-detail guidance based on typical materials supplied in these settings. Then we'll go to the next slide. So that begs the question, what more can be done? So in general, wider use of point prevalence testing could be a powerful tool for facilities who are truly trying to understand the spread within their facility. This process can be a little burdensome though, particularly in states where they do not have a lot of support outside. Some states like Minnesota, though, for example, have the National Guard conducting these point prevalence surveys. They have a lot of manpower going behind this and a lot of lab testing power. And just with any other infectious disease, general infection control procedures are very important to minimizing the spread. In general, if you're going to run a point prevalence survey, the data is not worth anything if you are not doing what is generally prescribed for infectious diseases in highly dense populations. So some of the best methods for reducing widespread COVID infections are the same outside of carceral settings as they are inside. So facilities that have implemented universal masking and increased access to antimicrobial soap and surface disinfectants will generally have less infections. And of course, as we always say in public health, education is fundamental to making healthy and informed decisions. Granted, this is not the only thing, and I think that's important to nail in, but incarcerated folks and the folks that are working in these settings need to be informed about how this disease spreads, what's happening on the outside, everything. This is essentially the foundation to successful multifaceted health interventions. But this can look different depending on the place and the layout of the facility. Readable, consumable materials like Carly was talking about need to be made and available in languages that are commonly spoken in a given area. Materials need to suit the specific layout of the facility and infection control measures that are available to them. Materials need to be widely dispersed across several different modalities in order for them to be successful. And then we'll go to the next slide. So all this to say, we have a long road ahead of us, even though we are several months into this pandemic. COVID rates continue to rise at alarming rates in carceral settings, and there's much more to be done to protect these populations. In our own state, there's a lot of variation in mitigation efforts. So shout out to Hennepin County, who has successfully decreased their jail population by quite a great rate, and then is also utilizing these materials that we're talking about today and specifically sought them out. However, kind of conversely, in the same exact state, we do have cases rising at an alarming rate, such as in NCF Faribault. There was just a point prevalence test done there, and over 200 individuals have tested positive in that facility. So there's a lot of variation even within the state of Minnesota, where we have a pretty strong public health infrastructure in place. So with that being said, we still have a lot of improvements to make from facility to facility, and a lot of efforts already in place need to be maintained for the foreseeable future. So that is just something we have to keep moving toward and keep making efforts toward in order to protect these populations that are in quite vulnerable environments. And then we'll just go to the next slide. That concludes our presentation. We will refer to the chat window for questions, so please let us know if you have any. And we have left our contact information if you have follow-up afterward.
Thanks, Karmen, and thanks to all of you. We do have some great questions in the Q&A box, and so I'll start ticking through those and just ask the co-presenters to chime in. I just want to hammer home the message here that, you know, prisons and jails are extensions of our community. And if we expect and want to control this pandemic and really truly address public health, we have to recognize that what is happening behind bars are extensions of our community. These are folks who are coming from communities, going back to communities, work in our communities, and public health really hinges on recognizing that these are not separate, they are not other. We have to acknowledge that prison health is public health. So with that, I'll turn it over to some questions, and we've, like I said, got some great ones here. I'll start with this question from Karmen regarding the video. So she says, I noticed that the video does not recommend masking. Can you address this? Yes, that's a really astute point. So at the time that we got this request in mid-March, masking, we were in kind of a PPE crisis. There was a lot of concern about availability of PPE and hospitals really ramping up. And I think I got the call from Dr. Winkleman on Sunday night before the state announcement the next day or later that day about schools. And so widespread use of masks was not recommended at that point. That has since changed, right? And we know that the public health messaging is very much wear a mask, everyone should be wearing a mask. And we've seen correctional facilities, jails and prisons start to ramp that up as well. Carly mentioned on the slide, or you saw on the timeline, that we've since been asked to adapt this video that we created for Hennepin County for a national audience. And in revising this video for a national audience, it also became clear that so much has changed since mid-March, including the widespread use of masks. And so the newer video that we're working on right now will include recommendations for masking. So that's a great question. Another question that came through is one about how public health professionals decide to channel their efforts. And I'm going to pitch this back to the panelists too and talk about this broadly regarding, so the question is, I'm curious how public health professionals decide to channel efforts, providing information to incarcerated people versus advocating for their release on the basis of public health concerns. As I said to Victoria in the chat window, I said, we're doing both, but let's expand on that answer here. So does anybody want to tackle that one?
I can start and then other folks chime in. I think in public health, we think about things as upstream and downstream approaches and middle stream. And so an upstream approach is getting at the root cause, right? The root cause is mass incarceration, especially of vulnerable populations with health disparities and health risks for COVID. And so that's where decarceration and even greater than that, addressing the policies that disproportionately lock up for people of color and that sort of thing. That's where that comes into play. And so that's really important. But then we're already in that situation, right? And so there also needs to be the downstream approaches and the middle stream approaches of educating and trying to mitigate the harm, like harm reduction in the moment, given the scenario. So I think it is both, and public health tries to take on a multifaceted approach to issues like this. And yeah, so that's sort of just a general high-level overview. But
yeah, I think that's a great answer, Rachel. I think the reality is that we're trying to do all of those things at the same time, and in a way that is complicated, right? Certainly, public health professionals are very busy these days. Another question came in about, it says some jails currently have a protocol of letting inmates out of their cells for only an hour a day, but after months of this, inmates are getting and showing their frustration. Is there a better protocol that can continue to reduce the infection transmission? It's a great point. I think that one of the real challenges is the huge variation in facility setup and the actual layout of each facility. As I started doing work in this space with jails and prisons now more than a decade ago, one of the things I hear my jail colleagues always say to me is, if you've been to one jail, you've been to one jail, because there's not a single jail in this state that looks like the next. Every prison is different, and their needs and their challenges are different. And because of that, it makes issuing protocols about how to handle control of the population really difficult. That said, there are some strategies that many facilities are using. In the prison setting, I know many facilities are trying to do what's called stay with unit, where they are having individuals who are housed together, eat together, stay together, play together, recreate together, etc., work together, and have actually moved individuals in the facility to try to keep sort of a single unit, so that if there is an infection, they can identify it earlier. But this also means that people can kind of continue to expand their recreation so that people aren't locked down for as long as they may otherwise be. In some respects, the parallel is this idea of, okay, I'm going to self-quarantine with one other family, or we're going to try to stay in that small network of folks. It's not great, and I think this is raising many of the concerns about the conditions of confinement and the real human rights considerations in terms of having people locked in for 23 of 24 hours a day, and what this means, particularly in a public health crisis. I think, the other thing that facilities are doing in terms of protocols is drastically trying to reduce their numbers. You can have more time, more space, more availability to recreate, to get people out of their cells, to go out into the courtyard, to get into the gym area. If you have fewer people in the facility, the population, the management is easier in that respect. And so it is both a slow the flow of folks coming into jails in terms of some of the things that Karmen talked about with regard to not detaining people pre-trial or limiting bail so that people can get out, but it is also getting people out that are still in terms of folks that are at particularly high risk or medically vulnerable, getting those folks out. So it is sort of a both and approach to that. Anything else others want to say or add on to that point? Great, and then I think we're doing well on time here. We've got another question from Whitney. She says, I'm wondering if there is information or data out there on how jailing protesters from the recent uprisings have affected the spread of COVID-19 in jails. Great question. Not one that I have a lot of data at my fingertips on, but Whitney, my email is here and on the screen, and I'm happy to do some digging and send you some information. I know that this was a huge concern for folks right out of the gate. I know that jails worked very hard to process people quickly and get them out so that they weren't staying in the facilities. And so the majority, a lot of community-based grassroots efforts to get people out, tremendous efforts to post bail for folks so that there was not really huge volumes of people who were staying in jails. Andy, were you going to say something on this?
Yeah, I will just add that I know that there's a current project being led by a first-year medical student who's been very involved with White Coat for Black Lives and very active in the protesting movement in Minneapolis, who is now leading a study on the transmission of COVID among protesters. So that is in the very early stages. I think they are collecting data right now. But my contact information is on this last slide. So if you're interested in following up, I can keep you tuned into how that is developing.
Thanks, Andy. And Karmen makes a really good point that I think many of us are seeing in the news as well, that right now research is showing very few COVID cases from the protests. I think this, as always, is a moving situation, and we'll continue to monitor this, but this is certainly something that as public health professionals, people were concerned about, and understandably so. Large gatherings of people, many of them were masked, of course, and that's helpful, and we're hoping that we don't see these large spikes following the protests. I think I have gotten through all of the questions. Maybe I'll turn it back to Kathy and Sarah, unless other folks have questions that they want to jump in with in the Q&A here.
Thank you, Rebecca. And I did see that there was a comment from Karmen that says that research shows very few COVID cases from protests. I guess we mentioned that, but are you guys familiar with that research? Did you say?
Yeah, there's been some recent work that's happening on that. Sorry, I saw thanks, Karmen McQuitty. Nice to see your name in the chat box. I thought it was Karmen, our student, but yes, very few cases so far. We're still monitoring. I think that we're seeing, because there have been protests nationwide, this is going to be something that we're going to continue to monitor, and certainly something that our Department of Health is actively paying attention to.
Okay, great. You guys really moved through a lot of material really quickly. And thank you very much. I think we always follow up with people afterwards and see if they have any other questions, but I also want to say to all the Hennepin County and City of Minneapolis, City of St. Paul people that are tuning in, that I asked our researcher, Professor Shlafer, if she would be willing to follow up with anybody that wanted further presentation or information, maybe presented to your unit or to your department or something like that around these issues. And she agreed that she would be. So, and thank you very much for putting up that slide with all your contact information. I think that question would apply to all of you. It sounds like you don't mind. If people do want to follow up with questions, they can just shoot you an email. And so people are pretty accessible. I myself have been calling people on the phone lately, and they've been answering. It's like kind of shocking. So please do think about bringing this back to your units and your departments, and finding out if people want to know more and want to get more involved. So
Kathy, the last thing, I didn't give a shout out earlier, but I do just want to acknowledge that in addition to this group of students that are on the call today, we've had tremendous support from the Hennepin County Sheriff's Office, including Edgar Linares and his help in the communications department. And I just want to acknowledge, right, that we've been able to do this and do this quickly because we got a clear ask and a need that was deeply rooted in the needs of the individuals in the jail. And with that, I think we can do good work collaboratively when we're listening to community voices and responding to a need in a timely fashion. And all of this has been in partnership with others. And so it's certainly not just the 5 of us represented on this call today. And just want to make that really clear.
and I have one last question myself to kind of follow up with. So you're researchers, and you just implemented a kind of an actual communication strategy. So is there any plan to follow up with regard to doing research to find out whether or not it was effective?
It's a great question. I hesitate to say anything other than of course, but I think the real challenge for us has been staying on top of this and sort of having new opportunities come and trying to figure out how do we respond to the need immediately as it happens. I certainly didn't expect to get this request from Dr. Winkleman on a Sunday night. Didn't expect to have it happen so fast. And didn't expect to get a request from a national audience to pump this out nationwide. So I'm trying to hold on as best as I can while having 4 kids at home, while working from home. I think the answer is yes, we'd love to. And if people are interested in partnering on that, we'd love to share the workload, as we're all feeling a little spread a little thin right now. And
well, and actually that's a big challenge for the county too, because everybody is just like making sure that they're responding to the stuff they need to respond to immediately. And as a matter of fact, there's been a little bit of a retraction that some people have heard from the county about how the need to like cut back on research and analysis right now while we focus our energies on getting done what we need to get done immediately. And also because of the impact on the budget associated with the pandemic. But I feel like meanwhile, I continue to hear people say that we need to do more research in a lot of different areas. So I think we're in that stage where, yes, there is some desire to pull back, but there's also a need to like start planning for like doing more data collection, more analysis to see whether or not some of these strategies are actually having the impact that we hope they would have.
Yeah, and I think the point prevalence estimates that Karmen talked about and the broader testing is going to be really key to our state. You know, thinking about whether or not this particular public health education material has an impact and in what way, I think is maybe less important than controlling the spread of the infection in the grand scheme of things. But I think still critically important, right? Are people getting this information? Is it being used? And I think one of the easiest questions we'll be able to ask is, as this rolls out to some of our national partners at the National Sheriff's Association and others, how many are using it, right? And I think that will be a good mark for us to say, okay, we've created something with no budget whatsoever, and very quickly, what could we do? What should we do? And my hope is that this will open up conversations with other jails and prisons across the country to say, here's what we need in terms of health education and health communication for incarcerated folks across the country, and not just for COVID, right? But how are we sharing health information with folks who are inside, who there is huge information inequality in terms of access to factual information inside. You know, this is not the availability of the internet like you and I have, and we can just jump online and ask a question about something. And that becomes critically important when we think about the health of incarcerated people. And so for me, I think it's a question of how can this be one stepping stone towards providing health education on all sorts of topics for incarcerated people in order to reduce health inequities and promote health and wellness for everyone.
And I also think that this maps over to non-incarcerated populations, some of which who do not communicate in the kind of the more typical ways of checking your email and your internet and your blah, 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 whatever it is. So I think that Hennepin County has, you know, 1/3 of the county budget is allocated towards human services and public health. And a lot of the populations that they deal with don't necessarily do the traditional mode of gathering information and processing it. And so I think that this, you know, that I think there's some crossover that could be done with regard to looking at the things that you're doing and how that could also be, those approaches could be utilized for other purposes.
Yeah, you know, that's absolutely right. So I'm a member of the Governor's Children's Cabinet Advisory Council, and just last week we were having a conversation about communicating with folks about who are in homeless shelters. So folks who are homeless or instably housed. And the conversation is very similar, right? How do we get health information about COVID, about the safety of testing, the availability of testing, the importance of masking? How do we reach folks who are disenfranchised in many, many ways to promote health equity when we know that really what most of our public health strategies have been focused on and not reaching the communities who need it, perhaps most.
I do want to take a couple seconds to just acknowledge a couple of some of the students to help with the translations. I realized that was an oversight on our part, but we had 3 students, Hodan, Musa, and Silvio, who volunteered their time at the drop of a dime. I don't remember what that to translate translate the transcripts and fill a need that we were not able to fill. So I do want to acknowledge them right now.
Thank you, Andy. I really appreciate you doing that.
So we're going to wrap up now, and we thank you all very much. This was like a information-packed session, and also demonstrates really amazing capabilities that the university has to offer, along with their some of you are alumni, some of you are PhD candidates. So it's like thank you very much, and I think this gives the Hennepin County staff hopefully a lot of ideas about ways that they can tap into the U as a resource as well. So thank you very much, and everyone have a good afternoon.
Thanks.
Thank you. Thanks for having us.
Bye-bye.